Hey everybody, it's Jessica DeMassa with WTF Health. What's the future of health? I am talking to the who's who of health tech and healthcare innovation. And today we are kicking off a brand new special series. We're calling it our Virtual Care Regulatory Roundup, and it's sponsored by our friends at Wheel. Wheel is the health tech company powering the virtual care industry, and they provide companies with everything they need to launch and scale virtual care services, including the regulatory infrastructure to deliver high quality and compliant care. And the reason we're going to do this is that we can all keep up to date on what's going on in the dynamically changing climate of regulatory affairs, health policy, and reimbursement when it comes to virtual care. We all need to know this stuff. And so we are checking in with experts monthly to get a state of play and find out what's going on. And our first expert here to help us out is Nate Lacktman. He is a partner at Foley Lardner, and he runs their national digital health and telemedicine practice there. He's also on ATA's board. So great person to kick this conversation off with. Nate, it's a pleasure to have you here.
Hi, Jess. It's a pleasure to be here. Thank you.
I am so excited to talk about this because I think, especially after the pandemic, we've all kind of gone through a lot in health tech and virtual care as far as trying to keep up with how things are changing, what things are going to stick, what things are going to go away now that the pandemic is waning. And so I'm happy to kick off this conversation with you and just check in. So why don't you just jump in for us, Nate? Like, give me a little bit of a state of play, particularly when it comes around some of the regulations that we've got our eyes on. What are you hearing, from your post as partner at Foley and Lardner, about, what's happening with cross-state licensure, with originating sites, some of the stuff that we love to talk about in terms of, eligible practitioners, some of this stuff. Like, what's happening right now?
Sure. Well, right now it's Monday at 2:30 Eastern time, which means there's about 2.5 hours left before HHS may or might not issue a letter saying we're going to non-renew the public health emergency. I'm going to put a marker down. I think they're going to not expire it in July, which means we'll have at least 150 days from now. And that really has been one of the big things that a lot of companies are talking with us about is what is going to happen or what should we do post PHE waivers. These last 2.5 years have been a sandbox of experimentation. A lot of the laws and rules that were so ingrained in the healthcare industry just went out the window. No co-pays, right? All these sorts of prizes, win $1 million if you get a COVID vaccination, things that you just can't do normally, they've been allowed. Virtual, no license required, all of these different things. So we've been able to experiment. Thus far, I have not seen any evidence of significant people getting hurt or healthcare failures in the quality, which is really great. And I'm hoping that we'll be able to learn from those lessons in the post-PHE environment. So we're talking a lot with clients about how to prepare for this transition of care because the public health emergency will at some point end.
So what is we're take that conversation the next step. So how are you helping prepare? What is your advice here on this as far as preparing for that? Okay, so here we have this deadline looming later today, but let's say it gets extended for 150 days. It's 151. We're back in the same spot. It gets extended again. How are businesses, specifically those who are in virtual care, expected to plan for what's ahead? And what is your best advice?
Yeah. I think the harder part for a virtual care company with these imposing ends of the waivers is balancing out patient continuity of care. That's what they're all about. I mean, if you weren't in healthcare, you wouldn't have these issues known as patient abandonment, which is when you say, I can't care for you anymore, and you haven't given the patient enough notice to find an alternative doctor. So if it was just widgets or bottled water, we'll say, sorry, we're out of that flavor. It's not allowed. So balancing that out and recognizing that these companies exist to help patients in the first place, it's integrally tied to their mission is important. So first one is licensing, right? A lot of states have already rolled back their licensing. That's on a state-by-state level, not a federal level. So I think that to the extent that you are doing services across multiple states and still availing yourself of a licensure exception, you need to say, well, what's going to happen? Do I get my doctor's licensed? Or do I say, hey, patient, we can't treat you virtually anymore. If you're in a border state and your catchment areas like that, maybe the patients will come in person. If not, then you look to see, well, what exceptions to medical licensure are there? Because I am practicing medicine, but maybe I can avail myself of an exception. And there are a number of them for pre-existing doctor-patient relationships, for follow-up care, for peer-to-peer consults, for emergencies, for just like even one-off. Some have like, oh, if it's on an occasional or infrequent basis, or if it's for free. And so it doesn't meet every single company's business model, but there are a number that do. So that's a licensure bucket. I
Yeah,
think I am not bullish on some sort of federal national
you're
license
not.
implemented. No, I
Okay.
think there's 10th Amendment and states' rights implications that have constitutional analysis that goes far beyond healthcare, and all sorts of regulated or licensed professions, from just home builders to health insurance companies to nail technicians. And I think it would really upend the entire revenue generating and localization of oversight on all of these different state models. Not saying it's impossible. The Sports Licensure Clarification Act happened, which allowed it for sports medicine. It's like the Sports Are Cool Act.
Oh, really? I don't know about this one. What is this? Real quick.
Yeah, I think it was 2018. They basically said, hey, if you're an athletic trainer or a doctor who has a contract with an athlete or a team or something like that, you can travel with that team, just being licensed in one state, and it supersedes any state license. So it was an example of federal preemption over states' rights on a medical licensure if you, as a doctor, are tied to sports somehow. So there
Interesting.
is precedent for it.
Okay, well, that's interesting. We'll have to keep our eye on that. So you're not bullish on state licensure. What about some of the other things that were waived during COVID, the originating site stuff, or any of the other like non-physician practitioner, some of those things? I mean, what's your sentiment on what's going to happen there moving forward?
I feel confident that the Medicare originating site, those type of restrictions will eventually go away. Thus, the concern obviously is that utilization would go up and it would be a budget buster. We have not yet seen that anywhere. In fact, already, while telehealth visits spiked for Medicare beneficiaries, they went down. They're still like 38x pre-COVID, but it shows it's not an unlimited, unmanageable spend for the Medicare program. When you had your interview with Roy Schoenberg a few weeks ago, he did a great remark about saying we shouldn't carve arbitrary fences into our own backyard. And I think that's a really great way to illustrate what these originating site restrictions are. They're largely immaterial these days. They were derived out of the HRSA's pilot program years ago for why to have telehealth in the first place. So with HRSA, rural, that's why they selected a rural patient population. And so it was almost like this conventional wisdom just passed forward without people really thinking, well, why are we having this in the first place? I'm confident that there will be a solve for that. If in the interim, then you'll just have to do a notice to the patient that they may be financially responsible out of pocket.
Interesting.
So
Okay.
that's the payment. I think on the prescribing, you have primarily prescribing of controlled substances, which remains an issue. In the last 5 years, a number of states have changed their laws, which previously prohibited telemedicine prescribing of controls, to expressly allow it. I don't have the total. We have 50 state memos. I don't have it memorized, but I'd say only about a dozen states or so may actually prohibit the practice or impose significant material limitations to render it essentially impossible, which is a large swath of the population that could avail themselves of it. It's the DEA. It's the Reinheit Act and DEA controlled substance registration. An in-person exam has been waived. That is scheduled to end when the PHE ends. And so a number of companies that are prescribing controls without having done it in person need to find ways to sort of pull the lever to have that one initial threshold in-person exam between the patient and the prescriber.
That's
And
interesting.
that's,
And I think, yeah, we've seen a lot of news around that lately in certain areas of healthcare. And so it'd be interesting to see how that continues to unfold. I'm curious about your thoughts on what's going on with the reimbursement landscape. Because I mean, we saw a lot of reimbursement at parity. We saw a lot done as far as remote patient monitoring over, and then as well as like, things involving asynchronous care versus synchronous care. So I'm curious about, in terms of payment for virtual care. I mean, what do you think is ahead for us here?
I don't anticipate a significant retraction from the payers post PHE, and that makes me happy. So
Yeah.
I've been like, gosh, I used to make this analogy when I was like speaking about this topic. It's like you could have the best Ferrari, but if there's no gasoline, it's not going to go anywhere. And that's really was something that inhibited hospitals and other providers from purchasing or investing in telemedicine. I think that the payers see the value of it. I am not as fearful. In fact, behind the scenes, I've probably written about half a dozen bills that got signed into law for telehealth commercial insurance coverage. And nobody's been reaching out to ask for help on that. in the last couple of years, probably because the states that did it temporarily, a number of them made it permanent.
Okay.
And those that didn't make it permanent, the market reacted like it should, with the consumers on the patient side, as well as the employer side, and the health plan saying, okay, this is what you want, we'll give it to you. And it worked out just fine on the overall med spend. I don't see, other than maybe some short technical coverage of certain rules, I don't see it going away. If you had to say what's mostly on the bubble, it's the audio only. Coverage for audio only is not universally agreed upon, even within the telemedicine industry, both for how casual a phone call can be, like from a clinical perspective, as well as how frequent and heavy of a lift medically should be justified to pay for it. Just a 2 or 3 minute phone call, nobody's going to pay for that.
Yeah.
But what if it was like a 15 versus a 25?
Okay, that's really interesting. Okay, so the duration of that as well, in terms of just how long you're interacting with the patient. I want to know your thoughts on some of the business models that are starting to really take hold here as a result, like, of the pandemic. I mean, because you've been around for a long time, Nate. I've seen you at how many hymns ago have we had we met? I mean, and you followed along in this space, and I mean, really helped kind of grow it up with us. And I'm curious, on your take as far as the market is concerned and what you're seeing out there among the not only the health tech virtual care entrepreneurs, but also the incumbent organizations that are starting to become more and more omnichannel. So I'm curious about, the way that you're watching some of these business models unfold. I mean, omnichannel, I feel like, has been the phrase of the year, like this past year especially. And so what do we need to know, like, from what you're seeing, like, what are some of the opportunities and issues maybe around that omnichannel model that we might not be thinking about as we do our business?
Sure. I mean, I like the concept of omni-channel, right? But it's, in some ways, it's just a digitized equivalent of what a hospital becoming a health system. Oh, let's have a rehab unit, let's have a SNF, let's have home health, let's have pharmacy, and we'll just do all things. And I don't know if I personally believe in, like, being a factotum, all things to all people doesn't necessarily mean that each one of those things is best in class. I prefer a company says, let me just choose 1 or 2 things and just be awesome at it, just be excellent. And then if you merge into another company, that you can then create this like collection of excellence. That's my personal take.
Okay.
What I'm seeing a lot more among the companies in telemedicine is continued interest in DTC, of course, but not like, oh, let's just do another urgent care alternative, or let's just do another hair loss or erectile dysfunction alternative. There are established companies that have got that very well dialed in. I do still see a lot of legs for async and DTC, but we're seeing now for click and mortar. So companies that started out as virtual only, now they're creating in areas where they have a high patient population, physical locations, so that they can do a more fulsome scope of services. So it's like the opposite from the playbook where, oh, I'm a traditional medical practice and I'll put up a sign on like the street corner, and maybe I'll now offer telehealth to my patients. It was like, we're telehealth only, but now we're moving it onto your turf. I love that, because then you could say, well, that's virtual first or whatever. But those are the examples of the companies that are taking some of the best for e-commerce, consumerism oriented plays of like delightful user experience with like, once you make a brick and mortar, the expectations of the patient as consumer walking in, I think they're just naturally higher. They see around, like, there's clinic stuff, there's blood pressure cuffs, and they expect a more traditional experience, but wrapped in this consumer-oriented vibe. That's going to be great. It also allows you to make your capital expenditures more strategically, rather than placing a bet that, oh, LA sounds like it might work. You already have ISP addresses from people who went to your website but didn't convert to patients, as well as your existing patient population. It's a better play. I think you're also going to see much more on that DTC async. I
want to hear what I was going to ask you. Like, what do you see there? Because like async, I feel like is like starting to have its moment. Like, it's not quite there yet, but I feel like I've been hearing it come up more and more. So what do you have your eye on there?
Yeah, like December 2018, I give this opening speech at a conference, and it was my theme was like, DTC async is gonna eat your lunch. It's better than phone call or this interactive audio video. And I got like booed by the audience, right? And they're like, "What are you talking about?" But I still firmly believe you do a robust online medical intake process. Couple that with high resolution photos if it's derm or lab results or diagnostics or software as a medical device built into the phone, which all of these technologies do exist. And then you have a way to have the patient-oriented intake where she doesn't get white coat syndrome because she's taking her time. And then you're validating the veracity with external clinically relevant medical information in the form of labs or whatnot. It gives the doctor even more information than what she would have had in a normal, just a video interaction like we are today. And I think it's proven up in the last 4 years that a lot of these DTC companies cracked that nut and figured it out. So what are they going to do at this next stage is two things. One, they're going to have more of like a house visit element for phlebotomists and at-home test kits and stuff to obtain that clinical information and become more omni-channel, so to speak. But they're also going to push to AI. I think that async is just a stepping stone to full AI automation. It's not there yet. It takes a lot of data, it takes a lot of ethics and structure and whatnot, but I do think that is the end game. Some of the stuff that we get to see working with clients behind the scenes does blow my mind that I'm like, I didn't think this stuff existed even in beta. So I'm very excited for that. The threat or the biggest concern is, will this take the human being aspect, the clinician professional out of medicine? And a lot of people say, well, medicine is an art. You could say law is an art, but I think even art, right? They have processes and you can dial in stuff. You can have standardization and efficiencies. Why? Because we have a fundamental supply-demand imbalance in our country for if you take all the clinicians who are available and all the patients, that's still not enough to match. And so what is our best available tool to try to bridge it is the use of technology to scale that and try to make that fit.
Curious too about your take on in this idea of scaling technology. I feel like we're seeing a lot more telehealth infrastructure companies, and I mentioned Real, who's supporting this series, and they're known in that space. But there are a number of others. You mentioned Amwell. I mean, there are quite a few, and even beyond those, that are providing telehealth as infrastructure to other companies, other health tech companies, other virtual care companies, some of those click and mortar clinics that you mentioned, and even incumbent organizations. What's your take on the infrastructure set of health tech businesses?
I love it. And I think it's just a further evidence of the timeline of the maturation of our industry, right? When I first got into it, there was like a few big telemedicine companies and then just a lot of like academic use of telemedicine. And those were sort of the be all end alls. But then you had this proliferation of all these kind of startups and whatnot changing it. And that's good. Competition is good. It used to be telemedicine against in-person, right? But now the industry got large enough that they were competing against one another. And then now the infrastructure plays say, hey, look, we're going to take some of the complicated stuff and make it, you can outsource it, right? You can't outsource everything, but what this has allowed to happen is startup companies, people with an idea to do something new and different, they can grow and flourish way faster than before. So that coupled with the COVID waivers and the just a lot amount of money in venture with the market overperformance was this confluence of like different events that gave birth to a ton of telemedicine digital health startups that wouldn't otherwise have been able to be there. So you gave an example for like clinicians and staffing and infrastructure. There's another one, I think, well, I won't mention any companies, but there are these headless EMRs that you interviewed someone about recently, which that did not exist 3 years ago.
No.
The telemedicine company, they're busy enough trying to say, how do I have the service model be new and different and let people know about it? But why are they having to build their own EMRs over and over and over? I love this vision. If we get here's a brass ring, okay? If a company comes out there to have a front end to do real-time patients benefit checks, all the patient has to do is type in her like group ID and health insurance, and it will say like immediately if it's covered or not with that telemedicine company, and if so, what is the copay? That would be lights out game changer, because then it takes all these retail plays, which has price anchoring, $5, $10, $15, whatever, and turns that into the same experience for a copay. All these cash only companies will then be much more comfortable moving to in-network, and people will avail themselves of their health insurance. That company or that technology doesn't exist yet. Right. And I'm waiting for it to come out.
All right, that's cool. I like that. That's a good one. It all goes back to payments. It all goes back to payments, Nate. All right, I want to get a couple last pieces of insight from you. And so I want to know, like, okay, you've been in this space for a long time, watched it evolve. Like we were just talking about some of the things that didn't exist before that exist now. Like, but we're still evolving. These waivers can go away. Things are still very dynamic. What keeps you up at night in terms of like, oh my God, the future of telehealth is in complete jeopardy if dot dot dot.
Oh gosh, I don't. Yeah, that's a great question. What keeps me up at night really is actually just enthusiasm and excitement.
Oh my gosh, Nate.
I know it sounds silly, but I don't look at the world through like a lens of like fear mongering. I think that companies should know that they're not like, here's the 10 things to be worried about, right? Because to every problem there is a solution, and most of the stuff out in healthcare, it's problems to be solved, not dilemmas that have no solve. So I do think information siloing is a problem. So, my firm, we have a blog that we put like all these different legal updates, and we give the full answer, link the primary source, and it's free, right? And so I think if we see more content of that, it gets the entrepreneurs and founders or executive operators comfortable that what they're doing is legal and compliant. So I guess if I had a concern, it's that if we have too much like non-compliance, right? Just too many reckless business models, which would violate, for example, anti-kickback statutes, Stark law, like basic fraud and abuse of the healthcare industry pipes. The regulators won't care how amazing or unique or clinically beneficial it is, if they'll just say your entire company's growth was built on illegal kickbacks. And I look at that as a shortcut that is tempting because there are so many rules in healthcare. If you break those rules, of course, you're going to grow faster than the other competition who's not breaking the rules.
Right.
The problem is it's a time-limited success. At some point, they'll hire someone like my law firm or whatnot to look under the hood, and they'll say, this isn't right, we have to change it. Or we won't invest in you, or we will, if you make the changes, does that change the valuation, like the growth rate?
Yeah.
And that has nothing, that's just the private enterprise growth, has nothing to do with an outside government regulator or patients filing class action lawsuits. So I do think it behooves the entrepreneurs to say, look, let's measure twice before we scale. Why? Because in e-commerce and digital health, you scale so fast. That's one of the exciting parts of it. But if there is like a little error or a gap, that error then is replicated tens of thousands of times over and over, which means the stakes are higher for any little mistake. So I know people want to move fast, and I think you can and should move fast in healthcare. There's a sense of urgency, but I think the entrepreneurs should, and established incumbents as well, find business models that are legally compliant, and then add your own flavor on doing something new and different. That is a secret sauce to success.
Okay, I love that. All right, last thing for you then. Leave us on a positive note here. Not only like, what could go wrong and how to mitigate against that, but like, I mean, like you said, energy and enthusiasm keeps you up at night. And so like energize and and help make enthusiastic the rest of us with like some parting words here. Like, I mean, you're in this space, and you have a very interesting perspective to me because you are on the legal side of things. So it's like, is there any one thing that we should know as health tech entrepreneurs, as those who are working to make virtual care stick broadly? Is there one thing that we should know or do to help kind of, get out of our own way and help advance the cause en masse and help kind of forward this continuation of the digitization of healthcare, to benefit all? I mean, inspire us, Nate.
Yeah, you can do it. If you're a would-be entrepreneur, or if you're like already in the mix, you can do it. There are business models and clinical and legal and payment solutions that work and are designed to comply with all the laws of all 50 states, be cost effective and scalable. Just find them and use them. Don't like throw up your hands out of fear. There's really only 4 fundamental things that I think make a successful telemedicine company, right? Meaningful to its users, whether you're like a software, the clinician's user, or the patient, or both. Clinically appropriate, right? Because it's got to be good medicine. Legally compliant, so you follow the rules and you can survive. And then scalable, so that you can duplicate it, or other people can essentially copy what you're doing, and more people can benefit from this idea. If you just have those 4 things, everything else will fall into place. I know there's like, oh, the market's going down, and VC Twitter is blowing up all this fear. Look, the founders and venture are different units who sometimes work in the same. But you don't need, especially with all these infrastructure plays and turnkey solutions, you don't need to raise a ton of venture capital to start your idea and make it great. In addition, the last like 5 years or so have really given birth to a number other health tech entrepreneurs who had some exits or took some off the table, they're going to be able to reinvest those into seeds of new companies and voices of unique and diverse people who haven't yet filtered up on the VC spectrum. I think we're going to see a second wave in the next few years of different types of founders targeting different areas within digital health that we haven't yet seen. And that I'm really looking forward to.
I am too. You did a great job inspiring us. I'm fired up. That's awesome. Nate, thank you so much. It's like this, I was really excited to speak with you because I really just wanted to get your take on what was going on broadly on more of the policy, legal reimbursement side of things. But talking to you about business model and talking to you about what you see as far as these trends about what's coming next, love having that perspective. Thank you so much for stopping by and sharing that with us.
Oh, thank you for having me. This was a blast.
All right, awesome. Well, Nate, thank you again. Thanks to our friends at Wheel for sponsoring this conversation specifically about what's happening in virtual care. I think we definitely got our money's worth with this one. I'm Jessica DeMassa, and for more interviews with the people who are changing the way that we do healthcare in and out of virtual care, I cover other stuff too. Head on over to my YouTube channel. It's over there at youtube.com/WTF Health. Once again, thanks to Nate Lacktman. He's a partner at Foley Lardner. Runs their telehealth and digital medicine practice nationally. And he's also on the board of ATA, who we love. And thanks again. We appreciate your time.